Welcome, friends, to another episode of 1PM. We're really excited to be collaborating with Becky from Becky's Notes, a UK-based resource to produce an infographic for our visual learners out there. Becky's Notes bring together all the key topics medical students need to know in a readily available place, reviewed by specialists in the field. You can check her out on Instagram at Becky's Notes 01 and support her at the links below.
Welcome everyone to another episode of 1PM. We've got a very special guest presenter. No, he's not really a guest presenter. He is integral 1PM member, Jay. We've also got some guests with us. I'm Adian, in case you don't know who I am. JT is over there looking at me.
Welcome.
And we have a special MD2 guest today, Alex.
Hi.
Yeah. What are we talking about today, Jay?
We're going to talk about Croup.
Take it away.
So Croup is only something you cover in MD3. But we want to show that as long as you have the right first principles, even if you're an MD2 or MD1 listening, you can also get by.
Okay. What do we know about Croup? There's another term that you can call...
I know what this is. Laryngotracheitis. Is that right?
Laryngotracheobronchitis.
That's the one.
That's a really long
very
name.
long name.
I got 2/3 of the way there.
All right. So, can everyone give me a definition of Croup? That'll get you 100% in your exam.
Good
Yeah.
question.
Yeah.
I wouldn't know, but I assume it's a cough of some sort. That's all I've got, sorry.
How about the itis? What does that mean
Itis.
in tracheolaryngobronchitis?
Inflammation.
Of the...
Larynx, the trachea, and the bronchioles or bronchus.
Well, the bronchi, not so much. I don't know why it's in the name, but...
Oh, really?
Yeah. It's more of the upper airways. So it's an upper respiratory illness characterized by a hoarse voice, barking cough, and stridor. The clinical symptoms are a result of inflammation and narrowing of the upper airway. All right? Now we're going to go through the anatomy and physiology of the upper airway quickly. So, where do we find the upper airway?
JT, you love anatomy. You've been hitting the Yankees hard. Get in it.
The upper airway is different to the lower airway.
There's like
and
a
the
border.
cutting off point
It's like a
is, I
border.
assume, based on the name. So the larynx is part of the upper airway, the trachea is part of the upper airway, but not the bronchus.
Thoracic.
Yeah.
Thoracic.
Thoracic,
outlet?
thoracic inlet.
Inlet. There you go.
Inlet.
Thoracic.
So, as JT said, the upper airway contains the larynx, the trachea, the glottic structures, so your subglottis, supraglottis, glottis, and epiglottis. So the boundaries of the thoracic inlet are ribs 1 and 2, upper edge of the sternum, and T1. What can you tell me about the microscopic features of the upper airway? What does it contain?
So, from memory, you have in the upper airway, because there's a lot of mechanical damage, you want squamous.
Okay, let's go a
epithelium?
bit broader
Yeah.
than squamous epithelium.
Okay. You've got the ones that are in layers.
You've got epithelium.
So you got mucosa, submucosa.
Yeah.
Mucosa, submucosa.
Right.
And then you have the C-shaped cartilage with the pars membranalis posteriorly, which contains the trachealis muscle, which just gives the airway its shape, like this C and the line on the bottom, right? And what can you tell me about the receptors present in the upper airway? There's a specific one.
Are these beta receptors? Alpha
The
receptors?
alpha receptors, yeah. We don't have beta receptors in the upper airway, which we'll come to when we do the management. It'll click together. All right, so pathophysiology of Croup, as we talked about, it's an itis, right?
Yeah.
So I'm going to put this question out to you guys. What starts off Croup?
Some sort of infection causing inflammation?
Just infiltration of a virus into the upper airway. Or it could be bacteria.
Like
You said
Usually viral. Usually viral.
But
What?
can
Could
be anything else,
bacterial,
right?
Yeah, it can be bacterial as well. So what does the body do when it detects a virus or some foreign body?
tries to kill it.
Yeah, so it sends the artillery in.
So shit.
It is first principle.
It is first
I
principle.
mean, you're not wrong.
We're trying to make it as simple as possible.
There's no Robin's pathology out there.
And then, obviously, when that comes in,
Yep.
what happens? You get vasodilation and increased vascular permeability.
Do you know why?
Because you're trying to get as many white blood cells to there as possible, maybe?
Sounds, I pay that.
Give that.
Yeah.
As we know, the upper airway has a fixed diameter because of that cartilage and the muscle on the back.
yeah.
That's
The
why I went through
trachealis
it.
muscle?
Yeah, that's why I went through it.
Okay, I see.
It has a fixed diameter, and as we know, in kids especially, the airway diameter is a lot smaller than adults. So it's like a quarter of the diameter. So if you have the same amount of blockage, you're going to have a higher resistance in a child's airway.
Because the diameter.
Because the diameter is really small. Yeah, it's small. Yeah.
Yeah, 1 inverse r to the power of
Yeah.
4.
Yeah, that formula.
That fancy
Yeah.
formula.
Yeah, and also they're a lot more floppy. Okay. Now, Alex, I'm going to ask you this question because you
Okay.
said you remember it. What are some common causes of Croup?
Respiratory viruses.
Can you be more specific?
RSV, maybe?
Close. What's the other one that's quite common in children other than
Sever-
RSV?
Also starts with R.
Nope.
Does it start with an I?
Starts with a P.
Parainfluenza.
Parainfluenza virus is the most common. I put the 5 most common ones you find in Australia, in Perth.
I think
Oh, wow,
JT's done an Anki about
Yeah.
this.
So what are the 5 ones? So Alex said RSV.
Yeah.
Looking for 4 more.
Is RSV something syncytial virus?
Respiratory syncytial virus.
Syncytial, okay. All right. Paravirus? Parainfluenza?
Yeah.
Okay, let's forget about para because that's the most common one. Looking for 5 others.
Oh, so
Five others.
In addition
Yeah,
to
5
Oh my
others
God.
compared.
Rotavirus?
That's
Isn't it
gastro.
the gastro?
That's
Rhino-
gastro.
Rhinovirus?
Right. Yeah.
Rhinovirus, yep.
Adenovirus.
Adenovirus. One that causes a rash with white spots in your
Oh.
mouth. Quite contagious.
Oh,
It's very
Oh,
contagious.
hum-
No,
First
it's
aid,
you're vaccinated against it.
you've been vaccinated against.
Measles.
Oh,
Oh.
shit.
Measles.
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 I was like, what?
What? It's still common?
No, it causes it. Like I had a kid in ED who had measles and he had croup
yes.
because of it, so I put it in here.
Ah,
You should never forget.
This is a red flag, right?
I think you should always have measles in
the
your
back
mind.
of your head.
But you-
And there's one more.
COVID.
No.
I'm
Hey,
sure
I think
that's-
COVID in 2023 is
It
not
doesn't
common.
cause croup though for some reason. I'm not really
Ah.
sure why.
Kids don't
It's
like
like
Causes MI.
bronchiolitis, I guess.
Because it's like too
Echo,
lower.
echo.
I don't know.
Echo.
Virus.
Echovirus.
That's an echovirus.
Echovirus, yeah.
How's in the top
It's
5?
news to
I
me.
have no idea. I just pulled off PCH guidelines and RCH guidelines.
It's like ECHO virus.
Echovirus, like
Maybe it's just
ECH.
Perth. Like, I don't
Yeah, it's
follow
just
Perth
Perth.
guidelines.
But, like, obviously-
we're international podcast.
We're
bro.
international. The most common cause of croup in India. TB. Okay. We're gonna. So that's your viral causes, right?
Yeah.
Now let's go into your bacterial causes.
Haemophilus influenza, surely.
Okay. Yes.
It's not common.
But
Doesn't exist anymore.
but.
You don't know it.
What is
Doesn't
another
exist.
name for a bacterial croup? It's quite important.
Bacterial croup.
Yeah.
What's the name for it?
It's bacterial tracheitis.
Yeah.
So you can have diphtheria, can cause a bacterial tracheitis, but obviously it's rare now because of DTP, diphtheria, tetanus, pertussis vaccine. And this bacterial croup commonly occurs due to a secondary infection after a primary viral infection more than a bacterial infection by itself.
Makes sense.
So most common causes of bacterial tracheitis. Number 1, this is the answer to every single question when they ask you, what is the most common cause?
Streptococcus pneumoniae. What?
Staph aureus?
Oh, really? Staph aureus?
Staph aureus.
What?
For kids?
Yeah.
Oh,
Staph aureus for kids, yeah.
Okay.
Number
Oh,
2
okay.
is Streptococcus pneumoniae.
Yeah.
Number 3,
Haemophilus influenza.
Haemophilus influenza. And number 4 is Moraxella catarrhalis.
Yes, my favorite one.
But Alex said Haemophilus influenzae, and JT said that it's rare. Why? Vaccinated. But obviously we have anti-vaxxers on the rise, so we want to keep an eye out for that as well. Okay, so you're an ED. It's 3 a.m. You go to see a kid with an illness and a cough. What features on history would make you think this is croup?
A barking cough.
What does a barking cough mean?
Cough that sounds like a bark.
Give us a bark.
I don't want to blow up people's ears.
You have a dog, right?
What kind of bark is it though? Is it a dog bark?
It's a dog bark.
A
not
cat bark?
It's a dog.
Isn't it seal?
Not
It's a seal.
Is
It's a
it
seal. It's a seal
Oh,
bark.
damn it.
You should own a seal.
Well, not gonna lie.
Sorry.
But when I heard the croup cough, it didn't sound like a seal bark. It just sounded like a very harsh, painful cough.
Whip out some YouTube video of a seal barking.
Yeah, it's Rochelle's job.
It doesn't. It actually doesn't sound like a.
And compared to an actual kid.
Okay,
Put a dog one as well. Nah.
but before the
Yeah.
barking cough, there's one like
Stridor.
trigger sentence.
Stridor.
Yes, that's a feature, but there's like a trigger thing that will make you think, oh, this is a croup
Like a
before you even
a-
see the child.
Oh, no, not a symptom.
No, it's not a symptom. It's like a feature on history.
Recent viral illness.
Yeah, so you have like a prodrome
Mm.
of a viral illness. What does that mean, Alex?
It's like a series of symptoms/signs,
What kind of symptoms?
like pathognomic
So
symptoms.
coryzal symptoms.
Oh,
So like
okay.
runny nose, fever, sore throat, sort of thing. Adian mentioned Stridor.
Yeah.
And is it inspiratory or expiratory?
It's an inspiratory stridor.
Can you explain to me why it's inspiratory Stridor?
Because there's both I's in inspiratory and stridor.
No. Well, yeah, probably.
And we
Yeah,
sort of
that's-
exceed
that is.
speed.
But I want the
Alright,
physiology.
here's
behind
one,
it.
here's
That's
one.
my little trick.
I remember.
It's probably not
I
useful.
remember this very clearly. Tell me if I'm wrong. I'm probably
Alright,
wrong.
we'll see.
So if it's an upper airway obstruction, in the sense that it's above the thoracic inlet, when you inspire, when your
Hold it.
lungs expand, you compress the upper airways because of negative pressure. So that exacerbates the obstruction, causing the inspiratory stridor. Is that right?
Close. So when you're he said that there's a negative pressure, right?
The negative pressure. So
Is it in the airway or is it somewhere else?
the negative pressure is generated in the airway.
It's in the thorax. Like the
Yeah.
negative, because the air has to come in from outside.
But then
right?
doesn't that like suck? Like,
Yeah,
sucks your
so
airways closed
yeah.
a bit.
So basically, when we want to breathe in, we have a higher pressure in the atmosphere and lower pressure in the chest, right?
Yeah.
We want to get air in, so it flows from a high concentration to a low concentration, right?
Yeah.
So what happens is as the high pressure air comes in, it sucks the airway closed. And then when you breathe out, your thoracic pressure is higher than atmospheric pressure, right? So what that happens is it opens up the airway as the air comes out because it's high pressure to low pressure, right? It's going to open the airway. There's another symptom I'm looking for, and
Yep.
it's quite pathognomonic for upper airway inflammation.
Wait, another symptom.
Yeah, it's another symptom. Or it could be a
Cough.
sign as well.
Cough.
Yeah, we already talked about the barking cough.
Oh yeah, cough. Stridor.
What if I told you the voice sounds a bit
Oh,
off?
hoarse.
Hoarse voice.
Hoarse voice.
Alex,
Yeah.
can you explain why they get a hoarse voice in croup?
Because of the inflammation.
Okay.
It's a real,
What
really
structure
basic.
would the inflammation have to extend into for you to get a hoarse voice?
Ah, the first principles.
First principles.
Surely
Remember all those?
glottis.
Yeah, it's the
Yes, I think
vocal
so,
cords,
yeah.
the glottis, yeah. So you basically want to get, well, you don't want to get, but the inflammation extends into the glottis, you get a hoarse voice. And fun
Right.
fact, every kid I've seen in the group so far has a hoarse voice.
Is that something that like the parents will usually say, oh, he's just like they've been sounding?
You
a bit
could
different?
ask that, or you could also watch the kid talk. And there's one more really important question you always want to ask to rule out a differential, which we'll come to later.
Are you an anti-vaxxer?
Vaccination status, right?
Yeah.
And that's quite important because that's
Yeah.
going to change what's causing. This
Don't ask
stridor.
like that. Sorry, I was just.
Yeah, are
doing
you an
this.
anti-vaxxer? We're moving on to examining the child. As we all exams start with general observation, and especially in pediatrics, it's quite important.
All right, Alex, go for your
Lead us off.
Go for your
Have you
General
been
obs.
listening to our
What
podcast?
What's the first thing you do when you walk into the room?
The patient looks really distressed, usually. Look at them, right?
How do you know this child? Oh shit! I need to get this child a resus now.
Mhm.
Versus I can take the history. Have you guys heard of the AVPU scale? So I'm like, I look at the patient and I'm like, hey, whatever your name is, and if they
Yeah.
respond to me, I know they're alert.
Okay.
So it's
Yeah.
alert, voice, pain, unresponsive.
Yeah, yeah.
Okay.
If they're anything below V, so pain or unresponsive, you can take them to resus straight away.
But I think the AVPU is mainly for kids. Yeah.
It's mainly for kids. Yeah, it's
okay,
important.
yeah.
That's why I wanted
Yeah.
to put it in here.
Yeah.
It's
Okay.
like
Good.
50%,
All right. Because in adults,
Yeah,
you would do a
GCS.
GCS or ABCDE or whatever.
Yeah.
Yeah. That's what you just see in your OSCEs. But
Yeah.
just to make that clear.
Okay. And Alex, you were talking about something else after.
So I
AVPU?
said several things.
Yeah. Can you go through those again?
See if they're well.
How do you know if they're well?
Usually, if they're like crying or if they're smiling still. If they're smiling still, they're fine. But if the child looks like they're whimpering or wincing every time they breathe, that person's not quite right.
And just saying, we haven't touched the kid yet. We're just
Yeah.
eyeballing
Yeah.
the kid. Right? Anything else you can talk about?
Like signs of, after you look at the general appearance,
Mhm.
maybe like looking for signs of extra work of breathing,
Okay,
like
we'll come to
JT
that
said.
next. We'll come to
Later?
that. Yeah, we want to look at color.
Colour,
first.
yeah.
Color. Any mottling. You know what mottling is?
See, in my mind, I know what mottling
Yeah,
is.
I
Like
can
heterogeneous
picture
colour?
it,
But
I-
I've never seen it on a kid.
It's just like
Like, is it different colors,
Yeah, it's
shades
different
on the
shades of
skin?
It's like
red on
grey.
the skin.
I've seen a few kids look grey.
yeah, it's like different color, and then you also have pallor.
Ah, yes.
And then obviously going to have the obs on the side there as you walk into the room, right?
Sure.
Yeah.
So you want to look at the blood
yeah,
pressure,
yeah.
They're hooked up to monitoring, sure.
Yeah.
blood pressure,
Yeah.
heart rate, O2 sats. And this is before you touch the child.
Yeah.
Now,
Mhm.
you're still at the end of the bed.
Yep.
As Alex said, you look for signs of increased work of breathing
Mhm.
Yeah.
or distress.
Yeah.
What are the signs of increased work of breathing? Oh, actually, I forgot to mention.
Ah.
If they're bradypneic, which is slow breathing, this is bad. Why is that bad?
Oh, they're fatigued.
They're fatigued. They can't breathe
Yikes.
anymore. So they're going to go into respiratory arrest
Rip.
anytime soon, right? So get them to resus straight away.
Call for help.
Yeah. And also hypotension is a very late sign in a kid. Go on, Alex. Sorry to disturb you.
You look at the ribs and see if there's I can't remember the name of it, but like you see that like the thorax is like contracting. You can see the ribs when they're breathing.
Like this
Intercostal
under
recessions?
here.
Yeah, that's the word. Yeah,
Intercostal, and there's
nice.
one more we're looking for.
Like the tracheal one?
No, still in recessions.
Oh, subcostal.
Subcostal, so
recessions.
subcostal intercostal recession. Okay, you said tracheal tug, abdominal breathing. And there's one more, which is something you're like, oh shit, this is not croup. They need to go somewhere very quickly.
Tripoding.
Tripoding. What is tripoding?
She's doing it.
Yeah,
Yeah,
let's go
nice.
for
They
it.
have their arms on their legs, they're leant forward, and they're like breathing into the ground. Why do you think they do that?
To recruit more accessory muscles.
Yeah, accessory muscles. You use your pec and your what are these called? Traps and they use the scalene muscles as well, and that opens up their because they look down, it opens their upper airway up. But this is more commonly seen than something else, which we'll come to later. Now,
Good stuff, Jay.
we auscultate. What are we listening for when we auscultate? What do you want to hear?
You want to hear the breathing.
Yeah.
Yeah, so you'd auscultate over the lungs.
A little bit more specific.
Auscultate.
You have two lungs, right?
Yeah, and you compare it from side
Why
to
do you compare both sides to see if you have equal
Yeah.
air entry on both sides?
Air entry is the main thing. Absence of air entry is bad. So looking for air
Yeah.
entry.
Do you also auscultate over the throat or no?
Don't have to. You can usually hit the stridor
Okay.
without a stethoscope on.
Yep.
And
That'd be
stri-
under your general observations. Like as you
It
walk,
could
as
be,
you walk
yeah.
in, you
It
hear
could- you could
you
be.
hear stridor, you
Could
hear
be.
cough.
But the caveat there is it can be at rest
Yeah.
or on exertion.
Okay.
Now,
Give me some push-ups.
give me some
Now
push-ups.
let me listen to your
Usually
chest.
you'd make the kid walk around the room and then you'd be able to hear the stridor. So examination, look at general obs.
Yeah.
Poo in all kids because it's a pediatric scale.
Mm-hmm.
We check the obs, we check if they look well, so like color, temperature, all of that stuff. And we look for signs of increased work of breathing. Okay, now we're going to look how to assess severity of croup because it informs management. It's quite important to
So
know.
is there a scale?
There's a score.
There's
There's
it's
a
not
freaking
a
score.
score. It's not a score. It's just
Wesley.
It's clinical
Wesler?
judgment.
Wesley.
Yeah, but you don't really use Wesley in
Yeah,
clinical
whatever.
practice.
Yeah.
That's an Anki.
Yeah,
You
that's
tell
an
us
Anki.
that. You tell
So-
us
He
that.
knows.
You have mild, moderate, severe, and life-threatening obstruction.
My favorite kind of scale.
Life-threatening.
Yeah, life-threatening.
Yikes.
If I tell you that most cases of croup are mild, can you tell me what you want to look out for to classify some kid as a mild case of croup?
Is it breathing stuff or is it something else?
It's just symptoms.
So they just got a inspiratory stridor at
Absence of stridor.
They usually don't have stridor.
don't have
Oh.
stridor.
Don't have
at the
stridor.
mild.
They
It's
have
not-
one
it's not
thing,
screwed up enough.
just one positive symptom.
A hoarse voice.
Barking cough, actually.
Oh.
So cough is one of the first things.
One of the first things is the presence of the ERT,
Okay.
the
yeah,
viral
yeah.
infection,
Prodrome.
prodrome.
Mhm.
Yeah.
And then you get the cough, then you get the stridor,
Gotcha.
and it goes and goes
Gotcha.
and goes.
Okay.
And they're usually normal behavior, so they're alert, they're interacting,
They're
they're
playing.
normal selves.
Yeah.
Mm-hmm.
But most parents, we know, they're quite worried about their child. They're going to bring
Yeah.
them into ED. So this is the most common type of croup you see.
Right.
Mild,
Mm-hmm.
mostly mild.
Anxious parents.
Anxious parents. Okay, now we're going to moderate,
Mm-hmm.
right? So we have the barking cough.
Yep.
What else do we need to add on to make it a moderate episode of croup?
Stridor on exertion.
Rest.
Oh.
Rest and exertion.
Okay.
Both.
Yeah. Stridor rest.
And exertion, but it's usually a mild stridor.
Mild stridor.
But the caveat here is, do you think the severity of stridor correlates with the actual level of obstruction?
No.
No, it doesn't.
Oh.
I remember that slide very clearly.
It doesn't. So no matter how bad the stridor is, the child can be well.
Mm-hmm.
You know, Jakey doesn't look convinced.
No, it is. It is. I'm
Can you
just
tell-
in
can
my
you tell-
thinking phase.
Can you tell your face that?
All right, so we have the stridor,
Yeah.
barking cough. What else?
I think hoarse voice is last, but
You
it's
don't
not.
usually get a hoarse voice in moderate.
Would be like the work of breathing stuff.
Work of breathing stuff. So what kind of work of breathing are you going to see?
In the moderate.
Yeah, in the moderate.
Wait, so when does a hoarse voice come in?
When the inflammation gets like, it starts spreading.
So that's severe, right?
That's like severe.
Also, that's what I just said. Hoarse voice is last.
I thought you meant in the moderate
Oh, no,
scale.
to come
I was like,
later,
how do you know my script?
No, because remember the three things that you told us was
Yeah,
the barking cough,
yeah.
the stridor, and hoarse voice
Yeah.
in that order.
Yeah.
Yeah.
Yeah, that's good.
Okay,
Yeah.
so mild sternal retraction plus or minus tracheal tug.
That's a moderate.
That's a moderate.
Okay.
And how would you describe the behavior of this child?
Probably quiet, unwell.
What's the pediatric
That's
term?
more severe.
Lethargy.
Oh, really?
They'd be like irritable,
Oh,
Irritable.
don't use that word though.
irritable or cranky,
Don't
or
use
Is it
it.
upset.
irritable for meningitis?
Yeah, but they're irritable in this.
This sounds like some Anki thing.
No.
Surely you can use irritable.
Well, like irritable is not pathognomonic for meningitis.
It's
is it?
not, but
Yeah.
she was whatever.
Sure.
Irritable or cranky or hangry or whatever.
So not a happy child.
Not a happy child, but they're still interested in
They're
the
still-
surroundings.
they're still
You can
doing
distract them with stuff,
Oh, okay.
right?
Yeah. You got
Bring a toy or some bubbles with you. They'll look at the bubbles and whatnot.
Gotcha.
It works. Okay, now we're going on to severe.
Yeah.
All right, so let's
Horse
start
voice.
off. Let's start off with stridor. What kind of stridor are you going to hear in this child?
Expiratory stridor. Or
Persistent.
That's
stridor.
that's the last.
the death.
That's a
Oh, sorry,
death.
life.
That's a death one. Yeah.
Yeah.
So
Death.
persistent stridor at rest.
Yeah,
And then work with breathing, Alex.
Yeah.
Yeah.
What are you going to see?
Everything.
Yeah, pretty much every sign you can think of. So
Nice,
it's
nice.
going to be severe.
Yeah.
Blah 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 whatever.
Yeah.
And then you can also see 3 other things:
Horse voice.
a hoarse voice.
3 other things. The behavior of the child.
Behavior of the child.
They're just lying.
They're going to be lying there,
flat.
using their whole energy to breathe, right?
Oh.
Would they be flat?
They'll be
They'd be
flat.
up, right?
They'll be
No,
flat.
as in, like,
no,
they-
as in
they
like
look-
that energy will be
they
flat.
look
Like,
Oh, but they would be lying flat, lying supine.
yeah,
Yeah. Okay.
45 degrees.
Yeah. Okay.
So when would you say the tripoding?
Usually that's more of a waiting room sign than a
Okay.
cubicle sign.
Uh-huh.
If you're going into ED, you also see drooling because they're scared to swallow,
Oh.
right? So it's
Because
going
there's-
to
'cause
come
obstruction's really
Yeah,
bad.
it's going to come
Ooh.
out through the front.
Right.
Going to see pallor and mottling. Those 2 are like dangerous signs as well because the child's not perfusing well, right? The
Peripheral.
peripheral perfusion is quite bad.
Gotcha.
And now we go into life-threatening obstruction.
Expiratory wheeze.
Yeah, so-
Thanks.
So the
Oh, sorry.
Not ways. I got that wrong.
the double
You
stridor.
guys don't yell at people, JT. What the heck?
Just raising my voice. I'm not yelling.
That's yelling. That's a definition of yelling.
JT's parents obviously didn't raise their voices at him enough.
You're just talking Cantonese, man. You just don't know.
It's the same thing. So expiratory
Both.
stridor
Like
and
you get
inspiratory
like a
stridor.
biphasic stridor,
Okay.
which is bad.
Yeah.
Bad. What happens to the child if they're not getting oxygen in and carbon dioxide out?
You mentioned it earlier, right?
Wait, what was that?
Hypercapnic respiratory acidosis.
Okay, that's not a clinical sign we can pick up.
Oh.
You're
Hyperventilation.
gonna look blue.
Yeah.
Cyanotic. You're gonna look cyanotic, right?
Cyanotic.
Okay.
That's bad. And then
Very bad.
again, drooling, really bad.
Drooling.
And the last one is like, oh shit.
Bradypnea.
AMS.
Absent
Ultimate.
Ultimate mental status, right? Decreased consciousness. So again, your ARPU scale comes in. If they're at U, unresponsive, straight. You gotta take them to resus.
Yeah.
Code blue.
Okay, so most cases of croup are mild. Remember that. And this is only like barking cough. You have very minimal stridor, mostly stridor and exertion, and they're usually normal behavior and no increased work of breathing. Your moderate cases are audible stridor at rest and exertion, barking cough, and you have some increased work of breathing, and the child is still alert, but they're irritable, right? Now in severe, you're going to have persistent stridor at rest, a lot of increased work of breathing, you're going to have drooling, pallor, and mottling. And in a life-threatening obstruction, child can look cyanotic, they'll have audible stridor, and the most important one is an altered mental status. And that's where your AVPU scale comes in again,
Yeah.
right? Now, how would you investigate croup? So a trick question, you don't usually do investigations for croup.
Mm-hmm.
It's a clinical diagnosis. But, in saying that, you can do some tests if you want to.
Mm-hmm.
So in terms of bloods, what do you think we can do?
What can we do? Bloods.
What bloods are there?
What bloods are there?
Like a million?
Like
VBG?
biochemistry.
Yeah, Adian said VBG. You said biochemistry, right?
Yeah.
That's close. VBG.
What are you looking in the biochemistry?
Like hypercapnia, hypocapnia. Like, but that's really late stage, hey?
Yeah. So, you can do a VBG in severely ill children, but I have never seen it being done
Yeah.
in my experience in the ED. But it can show some stuff, especially if a person is in respiratory distress.
Mm-hmm.
What kind of stuff do you think that is?
All right, Alex can take a break. You do it.
Yeah,
you're doing
JT
good.
brought it up before.
Yeah, JT's looking.
The
to
pH.
Yeah, the pH. So
Yeah.
what do you think it might show?
Because the high CO2
Yeah,
and
the
then
high
shifts that whole equation and then you get the low pH.
So you get a respiratory acidosis, right?
Yeah.
And eventually, if you don't treat the croup, it can progress to respiratory failure.
Type 1 or type 2?
Type 1
Two.
or type 2. Why?
Because the cutoff is like something on CO2.
Okay, let's think first principle. Why do you think we get hypoxemia and hypercapnia in croup?
There's an issue with ventilation.
Yeah, so you can't get air in, you can't get air
yeah.
out. So it just stays there, right?
Yeah, and there's an issue with ventilation. Yeah.
But usually you don't do a VBG. No one does a VBG.
Not for kids.
Not for kids.
Not
yeah.
for kids.
It's so weird, isn't it? Adults, like everybody, this guy come in, chuck a cannula in, take all the bloods from him.
Yeah.
Kids looking septic? Nah, fine. Resus.
Okay, you mentioned imaging, right?
Yeah.
What imaging would you do for this?
Chest X-ray.
Okay, but would you do it for all children?
No, only if they're pretty severe.
Question.
So you only do it for the kids who are admitted to
For me
ICU.
once.
Always.
Admitted to ICU,
Okay.
right? And there's a classic pathognomonic sign of croup on a chest X-ray.
Oh my god. What is a pathognomic sign of
It's called
croup?
the steeple sign.
Oh, I remember that radiology robot steeple
Robot.
sign. Yeah,
Robot.
Sorry, I
yeah.
didn't attend your lecture.
Steeple sign. So do we know what a steeple is?
It's like a thing in a church.
The thing on the top of the church, the pointy thing at the top of the church. Your upper airway looks exactly like that on an X-ray.
Cool. Alright, whatever.
Yeah. So, and if you want a picture of that, it's on the Notion.
Check out 1pm.wiki.
To all our audio listeners.
Yeah.
Okay, now we move on, as always, to management. Right. So the first thing we're going to do is principles of management,
Love it.
which is
Patient education.
patient education.
No, it's
patient,
relevant in
that's
this
true.
case.
Okay.
Yeah.
So, how do you think we decide what management to give a child?
Depending on its mild,
Severity.
moderate, or
Depending on the severity.
Or death.
Okay.
Pretty easy to manage, Jeff.
So principle is you treat according to clinical severity, right?
Yeah.
There is one medication across the board that all cases of croup get, or one
Oxygen.
class of medication.
Dexamethasone.
Steroids.
Steroids, glucocorticoids or steroids, right? And
Sorry.
Dexamethasone, as
Name 20 side
AD
effects.
as Adian said, is first line, and it's preferred. There are two reasons why. Can anyone tell me the two reasons?
Because you don't have to inject it. Nah.
You can inject dexamethasone.
Do you
Yeah,
know,
you
Do
can.
you know your first
I-
principles of steroid?
Of steroids.
Did you listen to the Cauda equine episode?
Caught out.
That's the same reason, right?
No, it's not all steroids do. It's not.
I haven't watched the Cauda
dexamethasone.
equina syndrome episode yet.
I don't think you're right.
Oh, you don't know.
I think you're back.
I don't know.
No,
Anti-inflammatory.
no, but
No, there's a reason why you.
Dex instead of like prednisolone?
Yeah, why would you pick
Oh.
Dex instead of Pred?
Fast acting.
More selective. I don't know.
Alpha.
Are you kidding me?
Go on that. What do you mean by more selective?
That's all I've got. Sorry. Sorry, G.
Related to the
More airway
anatomy of the.
So when you have a glucocorticoid, it can act as a mineralocorticoid or a glucocorticoid.
Oh Jesus.
So Dex acts as more of a
Pix.
glucocorticoid than a mineralocorticoid,
Yep.
right? That's reason one. Reason two,
What's the significance of that?
you get less side effects.
You don't want the mineralocorticoid effect. You want the glucocorticoid effect because the glucocorticoid effect is anti-inflammatory.
Oh, really?
Yeah.
Pred does both.
Really?
Yeah, Dex is only one.
What's the mineralocorticoid do?
That's your blood pressure.
Oh,
Yeah.
nice. We should have an episode on steroids.
Oh god. Okay, there's one more reason why you pick Dex over Pred or any other steroid for that fact.
Lies it?
You can nebulize it, but that's not the reason
Oh,
why.
okay.
Mm.
My bad.
What do you do when you give a steroid like a Pred? What do you need to do in the long term?
Wean it?
You need to wean it, so you give like a 3-day course of
Ah.
Pred. But a Dex is only one off dose.
Short acting.
It's short acting. You only need to give one dose of Dex versus 3 days of Pred.
Just settle it.
Yeah,
Settle
which
it ASAP.
obviously you'd prefer the one off dose, right?
ASAP Rocky.
Unless you don't have access to Dex, then you would give them Prednisolone.
Right.
Okay.
But most GPs, paramedics,
Paramedics.
usually give Prednisolone.
Because they don't have Dex.
They don't have Dex. You need to
Ah.
continue that instead of giving them Dex. If not, you'll send them into adrenal crisis.
Yeah.
All right, so and then you, as Aiden said, educate about croup. You give them the fact sheet about croup. In terms of nursing, we want to do ALIOBS. Keep the patient comfortable, because what happens if they're not comfortable and they're distressed? What's going to happen?
Worsens the
They're
respiratory.
going to get spasm of the vocal cords.
Oh my gosh, spasm.
Cords, right? So, how do you keep the patient not distressed?
Keep them with the parents.
Keep them with the parents.
Play some videos.
Yes,
Keep
okay.
them like in a room.
So the way it works with kids is the parents get your vibe and the child gets the parents' vibe. So if you're up here,
Mirroring.
if you're up here
Yeah.
confident, the
Yeah.
mom's gonna be relaxed, child's gonna be relaxed.
Yeah.
It's very easy
So
to
you-
just be confident.
So you
Yeah.
don't give the stickers to the kid, give it to the parents.
I'm sure they'll love it.
So even if you're not confident, just puff your chest out, be nice.
Be a lobster.
Have that false sense of confidence.
It's very hard in medicine.
Right, but
Imposter syndrome is very high.
obviously, but the more you do it, the better
Yeah.
you'll get at it.
Makes
right?
sense. Makes
Yeah.
sense.
The last principle is use of adrenaline
Yeah.
and not salbutamol.
Yeah.
Why don't we use salbutamol?
First principles.
Let's go,
We'll
JT.
come back to the first principles. Looking at
Do you remember where? Upper
don't.
airway, lower airway.
Because you said that the upper airway has more alpha receptors and the lower has more beta receptors.
There are no beta receptors in the upper
Oh, it's-
airway. It's
yeah.
just alpha
Yeah.
purely.
But then they have more then. definitely.
You have more. Just like, again, wording. So what happens when adrenaline goes and binds to this? What's going to happen?
It's gonna dilate.
It's going to dilate.
Vasoconstrict bronchodilator.
Bronchodilate.
Yeah.
Or as we call it, tracheodilation.
Cool.
True, it's not the brain,
Oh.
the bronchi.
It's
Yeah.
not the bronchi, right?
Yeah.
Okay. And the last one is admission. Only done for severe cases. And if there's no stridor, rule of thumb, no stridor, no admission.
Oh, nice.
So in the moderate,
I like that.
moderate one also doesn't need admission.
Depends.
If they have
We'll,
stridor.
we'll get to it.
Depends.
Now we're going to go into the specifics of management according to severity.
Yeah.
Starting with non-medical always, keep the child happy, LDOBs, and droplet precautions. Okay, for a mild case, what do you think we're going to do?
Patient education.
Reassure the parents, reassure the kid.
What did I say that all children get?
Dex.
Dex, yeah, all children, every group case gets dexamethasone.
Yeah.
How much Dex and how long?
Okay, so you give oral dexamethasone and 0.15 milligrams per kilogram.
Oh my god, wait. I hate weights.
It's to do with weights, yeah.
Yeah.
And that's a one-off dose. And
Okay.
usually you'll see an improvement within 30 minutes
Yeah, okay.
for mild cases, right? And then you safely discharge them with the group health fact sheet.
Ah,
Okay.
you're missing one thing. Okay,
Yes.
you're missing one thing. JT, you want to tell them what you're missing?
Safety netting.
Safety.
Safety net, yeah, I was going to come to that.
Oh,
I was
okay,
going to come
so-
to
so-
that. Yeah, I was going to come to that. So
That's
then
for Alex. You can say that later.
Yeah.
you always safety
Say
net.
these buzzwords.
What does safety net mean, Alex?
Is to make sure that if the patient gets these red flag symptoms, that they come back to the clinical practice.
Basically covering your ass,
Fair.
right?
No, but I like her explanation.
But not just
Good.
red flags.
Yeah.
Or like any other
Like,
symptoms.
If they're just worried.
Yeah.
If they're worsening, if you're worried, please come back to ED or go see your GP,
Mhm.
right? And would you follow them up?
For croup,
Yeah. Would you follow them up with the GP?
It's always yes.
yes.
Yes, you always follow them up with the GP.
Okay.
So in about
Thank you.
48 to
Trick
72
question. Trick question.
48 to 72 hours, you'll follow them up with the GP.
Okay.
Let's go with moderate now.
Dex.
Yeah.
Okay.
No, sorry. Patient education.
No.
Oh.
What do you do before all of that? Let's say the stats are dropping.
Oxygen.
Low flow oxygen, and
Mhm.
what is the indication to give oxygen?
O2 sats are dropping.
Okay, there's a cutoff
Okay.
for O2 sats.
Below 95.
Less than 92 usually.
Okay.
And what do you aim for?
Your name for 98.
Above 96.
Okay.
usually, Right? And then JT said, what do you give after
Oh,
oxygen?
Dex.
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 He's like, give more oxygen.
Then you give oral Dex again.
Dex.
0.15 milligrams per kilogram.
Yep.
Oral. What if they're vomiting?
Oh my
Sublingual?
god.
IV.
IV.
IVs.
IV Dex.
And if they improve, what do you do?
Keep monitoring
Yeah.
early obs. Reassure of the patient. Reassure of the parent. Safety netting.
Basically, if you think of
Fact
it
sheets.
as a flow chart, you just treat it as a mild case of croup.
Jumps into the
drops into the mild now,
yeah,
and then
okay.
once they're after mild, you can go send them home.
Yeah.
GP follow up.
Usually, GP follow. Usually, it's 4 hours you observe them for, and then you send them home. What if they're deteriorating? What if they don't improve?
Cough help.
Call for
help, and then you treat them as severe,
Mm.
right? So they drop
Oh,
down.
okay.
What if there's
Pathway.
no change?
Definitely cough help.
What if
Wait,
they're staying the same? They haven't changed. They haven't improved or deteriorated. What do you do?
They're not improving. They're not deteriorating. Give them
Yes.
more Dex.
It's a single dose. So you need.
So you admit them to the short stay unit for observation, and then if they deteriorate from there, take them to resus, treat them as severe.
Treat it severe.
And if they improve, treat them as mild.
Yeah.
Sorry, mild, and then you discharge them home.
Yeah, yeah.
Gotcha.
Okay, now we get into the juicy stuff.
Yeah.
Severe. What's the first thing you need to do?
Cough help.
Call for help.
Dex.
Okay, before Dex.
Fucking oxygen.
Oxygen.
Just repeat it.
Always oxygen. So high flow oxygen.
Yeah.
Aiming for sats above 96.
High flow oxygen. though.
High
So
flow. High flow oxygen now.
So like high flow nasal prongs.
Yes. Or like you can do like
15
a
liters, right?
non-rebreather or whatever you want. And also high flow nasal cannon if you want. Depending. It's
Humidified.
some clinicians prefer this or that.
Yeah.
Whatever the consultant prefers, you
Yeah.
do. What's the next thing you need to do?
Dex.
Before Dex. It falls into ABCD assessment.
Airway.
Establish IV access.
Establish IV access. Established IV access. And then you give Dex.
IV Dex.
IV Dex. And this is
0.15.
0.6 milligrams per kilogram.
I'll follow guidelines.
Follow the guidelines. And then something else you need to give after the Dex.
Adrenaline.
Adrenaline.
Yeah.
What kind of adrenaline? Intramuscular, IV, nebulized?
Nebulized.
Nebulized adrenaline.
Because you want to get to the
Yeah,
to
want to get to the
throats,
airway.
yeah.
So you give 1 in 1,000 nebulized adrenaline at 0.5 milligrams per kilogram per dose
Follow the guidelines. Follow the guidelines.
every 15 minutes.
Yeah. Yeah.
Right? And then you assess them
every 15
then
minutes.
you assess
Right,
them every
that's
15
important,
minutes.
I think. Yeah.
Then you
Alright.
assess them
Give the allotted dose every 15 minutes.
Yes.
Of your local guidelines.
According to
and then you
guidelines.
assess them every 15 minutes.
Yeah.
And then
Yes.
you observe them for 3 hours minimum. And if they're improving, what do you do?
Manage them
Jump to
as-
moderate.
as
Actually, no.
Jump
Go
to
straight to mild.
No.
Admit.
No.
You admit to short stay until stridor or distress decreases.
Until
And then you treat them as mild. What if they're not improving? What if they're deteriorating?
Recess.
ICU admission.
So you call a consultant to come and review them. You give them more adrenaline. You call the ICU team.
ICU team.
And then anesthetics.
Awesome. Love the answer.
Why do you call anesthetics?
In case you need to intubate.
In case you need to
Intubate.
intubate.
Obstruction.
Now, life-threatening obstruction. What do we do?
Call for help.
Before you call for help,
ATE assessment.
take them to resus.
Yeah.
Take
The
them to
help is
resus.
waiting for you.
Yeah.
Yeah, take them to resus, call them at call ENT, anesthetic ICU team, call them all. Start high flow oxygen, but bilateral IV access. Then you give them IV Dex at 0.6 milligrams per kilogram, nebulized adrenaline, and then you prepare to intubate.
because the anesthetics team.
Because anesthetics are coming down, you need to prepare them to intubate. And that's a whole other topic. We're not going to go into that. So we've done medical, non-medical, and we're doing surgical. What can you do surgically for these patients?
Tracheostomy.
Tracheostomy.
Yeah.
If you
That's
can't,
surgical?
If you can't secure an airway, do a
Surgical
tracheostomy.
airway.
Yeah. Quick speed run through the principles again.
Yeah.
So what do all children get with croup?
Dex.
They get Dex.
Different doses,
and if you
local
don't-
guidelines.
And if you don't have Dex,
Prednisolone.
Prednisolone. All right, and then you need to wean them off that.
Yeah.
And give them a 3-day course instead of one-off dose.
Yeah.
And then your management depends on the severity, and the more severe cases get adrenaline,
Nice.
Nebulized.
nebulized adrenaline. And then you also consider oxygen.
1 in 1,000. Keep going.
You got this.
And
15 minutes.
And if their stats are less than 92, consider oxygen.
Gotcha.
High flow, low flow, depending on your clinical judgment.
Mm-hmm.
Okay, we're nearly done. We're going to go to complications now.
Death.
Death. And then you have death. You have asphyxiation, which is pretty much the same thing.
Death secondary to asphyxiation.
Asphyxiation. Then we talked about this earlier, but it's more of a long-term complication. Bacterial tracheitis.
Oh.
Yeah.
Even if you treat
Okay.
the croup, you can still get a
Okay.
bacterial
Oh,
tracheitis.
the
Yeah,
viral.
the
Yeah.
secondary bacterial infection, right?
Gotcha.
Yeah.
You can also get a severe lifelong disability if they're not resuscitated promptly.
Ah,
If
yes.
you get airway access or not.
Yeah.
The last one is recurrent episodes of croup.
Why do we think that is?
Because they were probably more likely to get croup in the first place, and then or something due to the infection caused by the virus or the bacteria that predisposes them, like worsens their airway to get
Yeah.
more croup.
Yeah,
in the
pretty
future.
pretty much.
One of those reasons.
Sounds good.
Yeah.
Yeah.
I'm going to go into differentials for croup. We have 3 big ones here that you don't want to miss. We have 3 people on the table.
I go with the sexy one, epiglottitis.
Damn it.
Epiglottitis.
Fail.
Due to
Yes.
Haemophilus influenza.
And then how do these kids usually present?
They present toxic.
What does toxic mean?
They look sick af, drooling, can't swallow, tripoding. They're like just
Is
flat.
that the word toxic?
Yeah, the word is toxic. They look
Oh.
toxic.
And
have
is that
s-
reserved for?
like really sick
Sick
kids?
Oh, okay.
Like think
alright.
septic kid.
Yeah.
So excessive drilling, tripoding, and they appear toxic.
Yeah.
And this is when your vaccination history comes in.
Mm.
Yeah, yeah.
It's quite important to know. Okay, Adrian got epiglottitis.
Jeez.
There's 2 more.
Finding it out.
Not as sexy.
Is this like steak?
Steak. They could be eating steak. Yeah, you can have this if you eat steak. I don't know. You could have a chicken as well.
Do you know it? Is this one of the differentials?
Steak.
Yeah.
It is. Do you
Wait,
know?
what? No, I'm completely
you-
lost.
you say.
Yeah, what is
Foreign body obstruction.
Inhaled foreign body.
Ah.
Yeah. Inhaled foreign body.
Okay, moving on.
Okay.
I thought
Okay.
I gave you the easy one, but
So-
now I don't know what the third one is.
How would you pull that out from history? An inhaled foreign
Oh.
body.
Just ask him. Surely that's one of them.
It's like, did
You
you
should
ever
have a
take your
meal.
eyes off your
Yeah,
kid?
if they arise of kid. And also the history that's not consistent with the ERT prodrome. But the catch here is 20% of kids with croup don't have the prodrome. So that's why, if the treatment's not working, think about the differentials.
Mhm.
Yeah.
Right? The last one for Alex.
Oh, anaphylaxis.
Anaphylaxis.
Uh,
What do you look out for from a kid with anaphylaxis?
Like respiratory distress, obviously. What else? Okay.
Use that
Decreased
word that
consciousness. Angioedema, is that it?
Angioedema, stridor, and hoarseness in the voice.
Okay.
The real kicker difference here is the angioedema. You don't get angioedema in croup. But the
Mm.
other 2 you can get in croup.
Mm-hmm.
Gotcha.
So that's why you need to do a thorough bed exam
You
before.
see peanut butter on their grubby little head.
Yes. But it can be due to a known or an unknown allergy.
Yeah.
Right?
Yep.
So you don't always know. Use your clinical judgment. Okay, we're at the end. 3 takeaways. Number 1, croup classically presents with a prodrome of an ERT, upper respiratory tract infection, barking cough, plus or minus stridor. Number 2 is all children with a croup should receive steroids. Dex if available, or a 3-day course of prednisolone if you don't have Dex. Number 3, if croup does not fit the picture, think of other differentials. What are those 3 differentials, Alex?
Good question. Anaphylaxis, foreign body. I love how that's going to be a thing now. And the last one is epiglottitis.
Yep. Excellent. And if you want more information on this, please refer to the resources section in the Notion page.
1pm.wiki.
Yeah, we're done.
Nice.
Thank you so much, Jay.
Yeah, abrupt.
Thanks, Jay. There we go.
Oh, was that abrupt ending?
Thank you so much for listening. If you've enjoyed this episode, please leave us a review and share it with your friends. It helps us get discovered and helps more medical students with understanding their first principles. Check out 1pm.wiki, and for all your first principles, keep it right here at 1pm.